So my name is Mark Navin. I'm a trained philosopher and bioethicist. My scholarly work is in ethics in medicine, and specifically in ethics in clinical communication. I also do some work on ethics in public health. I've got a couple books on like people refusing vaccines and what the heck that's doing to us as a society. Frightening stuff sometimes. But I also in December finished the accelerated second degree. So yay, nursing. Yay. Oh, okay, that's very kind. Well, and congrats to you being in your junior year. It's an amazing program, and you're going to do great. And so excited to hear about what's going on in clinic. So we're going to have some time talking with each other. I'm going to give you a lot of energy. I'm going to ask for at least some of it back. Yeah, I know you're tired. I know you have a lot going on, but like you also have been paying attention. You also have been in clinic. When did you? So you're doing clinic right now for this class. You've done MedSurg 1 as well. You're doing MedSurg. So you have 2 clinicals at the same time. Okay, so you got some experience. And how many of you have worked as like aides or techs or UAPs? So you guys have been in clinic. You've seen some things. I want to talk about things you've seen. So my training, right, is in philosophy. I chair the department. Has anyone taken oh, very good, familiar faces. Okay, so sorry that you have to see me again, but it'll be okay. It'll be over in like an hour. There you go. I want to talk about ethics, and I don't want to talk about it in a philosophically heady way. I'm not going to throw a lot of theory at you. I'm going to talk about ethics in this way. All of us care about things going well. Most of you are here because you've got a kind of ethical vision about why you want to be a nurse. Most of you realize the world is deeply unjust, and our medical systems are broken. Mental health care in this system is a disaster. Right? And so you are trying to do good in the midst of a broken world, right? Regardless of what you think about philosophy, you have ethical judgments. You're making them all the time. And part of your ethical judgments is about protecting your own conscience, right? Protecting your own character, trying to be the kind of person who doesn't get burned out, right? Moral distress is one of the primary reasons people get burned out and quit healthcare professions. Right? I'm not saying there's a magic cure, but being very attentive to the ethical dimensions of the work you do, being able to talk with other people about that, being able to even just to name what's wrong, right? Being able to name it, to talk about it, communicate about it, and do maybe just a little bit to make things better, that can help you. I hope it can. It helps a lot of people. So I hope this will be relevant. I'm going to talk today about a lot of cases. We're going to throw around a lot of ideas. In some ways, talking about ethics is like learning a foreign language. It's a vocabulary to express ideas you already have, but maybe don't know how to express really well, so you can communicate those well with each other. But I'm sure all of you think some things are effed up in healthcare and nursing, right? I certainly do. Nurses don't unionize for nothing. 10,000 nurses at Corewell Health East, right, voted to ratify, to give their negotiating team the power to walk out in a strike, likely to happen in the next days or weeks. That doesn't happen because people think things are going well, right? Okay, well, we're not doing unionizing. That's all I'll say about the union. Yeah, you just looked at me bad. It's gonna be okay. Let's start with this question. The psychiatric nurse describes a situation to you, or maybe this is you as a psychiatric nurse. You're trying to persuade a patient to take oral meds. And you know that this patient who's increasingly agitated and is just maybe even decompensating a bit, that if they refuse, it's likely, if the trajectory goes the way it's going, the physician's going to order a sort of involuntary injection because they are not going in a good direction. Now, the nurse's persuasion succeeds. The patient takes the pill, but you might ask yourself afterwards, did the patient voluntarily take these pills? Was my persuasion really about informed consent? Was I really respecting the patient's autonomy and dignity? Or was there like a hidden threat that maybe I said out loud, or maybe I just knew and it motivated me, that really this was coercion? Take the pills or else you know what is going to happen. And so I guess the first question for you is just, what do you think about that kind of case? Because this isn't familiar. I mean, this isn't unfamiliar. This isn't unusual. Is this coercion? Is this a use of a threat, implied or actual, against a patient? And here are sort of 3 sort of possible answers. Yes, the threat of forced injection makes that choice illusory. The patient might think they're making a choice, but there's no choice at all. They're going to get the meds one way or the other. No, well, the nurse persuaded. The nurse didn't hold anybody down. And then maybe you want to know, it depends. I need more information. Lucky you. We got a whole hour plus together. So I guess The question I ask you is this, maybe pair and share quickly with someone next to you, just to say it out loud, just to be accountable. Which of these do you think is the best answer? I don't want any D, E, or F answers that you're making up. A, B, or C, quickly say why to someone next to you. Go right now, just for a moment. I just want accountability. Get it on record.
I'm going to go with C.
You're a C, okay.
Yeah.
The C is the cop out, but you know, it's probably right. That's right. That's good, that's good. Okay, we're going to talk some more about this case. I just want you on record as having said something. Here's the goal for today. We're going to do a whole like philosophy class in like an hour. It's going to be great. Anybody read an Immanuel Kant? You've read some Immanuel Kant. Well, you're supposed to have read some Immanuel Kant. Maybe you didn't read it. There'll be no Kant or John Stuart Mill or Aristotle today, I promise. But we'll be talking about some ideas that are relevant. Here's two main things we're going to do. I'm going to spend a few minutes talking about ethical frameworks. And the reason to talk about ethical frameworks is it's a vocabulary to use to talk about ideas you already have so that other people know what you're talking about. Right? Nursing practice and research has decades and decades of tradition and of an established literature, including on nursing ethics. In fact, some of the most cited nursing journals are actually nursing ethics journals, right? Writing about ethical issues unique to nursing practice. And so I'm going to talk about some of the ideas that you'll see reflected there, not because they're interesting just for abstract philosopher, weird people like me that want to think about them and write about them, but because they give you a language to talk to each other about. And I want to be clear, it's the language that like corporate medicine and nursing are talking about already. So if you want to know like what do they mean when they're talking about this stuff, here's part of it. And then I'm just going to walk through some cases, some broad issues. You'll see coercion is our number one. So toolkit. Let's start. Some frameworks. This is the classic framework. The four principles of bioethics. If you're taking a bioethics class, like these are our four principles, and they are a useful set of ideas because they matter no matter where you are and to everybody. Right? Have you seen, anybody seen these before? You've seen these, yeah? So autonomy, right? This is about respecting self-determination of the patient. The patient ultimately gets to choose, especially if they have the capacity to do so. Beneficence, that's why all you're here. You want to do well by your patients, right? Those can be in conflict. Why? When what's good for the patient is not something they're accepting. Maybe they're refusing. Maybe they're acting in ways that are going to be actively harmful to themselves. Beneficence and autonomy are often in a conflict, as we'll talk about later today. Non-maleficence, right? Avoiding harm, especially avoiding dignitary harms, both to individuals and to groups. So much of the history of medicine, so much of the history of psychiatry involves very harmful attacks on people, both in sort of physical and emotional ways, but also in sort of dignitarian ways, right? Ways that undermine their sort of status as beings that deserve respect. And then justice, right? Are we treating patients equally based on race, based on gender, right? Based on socioeconomic status? Are we allocating scarce resources appropriately? That's something that's sometimes hard to navigate at bedside, but it's an issue that should be in the back of your mind. Our system is deeply unfair. Our system is deeply unjust. Your access to both medical care and especially outpatient mental health care depends so much on like how good your insurance is, and frankly, where in the country you live. Like, I've been dealing with the psychiatric issue with one of my 3 kids for years now. We just got a diagnosis of autism spectrum disorder, and like now our insurance will cover stuff that, boy, I wish it would have covered before. We could have used that for the last years, but if we finally got a diagnosis, I guess now the insurance thinks we can get it. If you've ever dealt with the system, injustice is rampant, right? Okay, a couple of big sort of themes that we'll think about today. Deontology, you don't have to know this word, but one sort of core ethical principle sometimes people have is, hey, there are some things you should never do to people. There's some things it's always wrong to do to people. We might disagree about what those are, but if you have that kind of intuition, you have a kind of deontological intuition. Deontology just means duty, that there's some things you ought not to do to people. One core idea here is that people are not objects. Right? One of the phrases turned around is they're not mere means. They're not just instruments for you to make more good happen in the world, even if it's good for them. But people are themselves beings of infinite worth. If you have that intuition, then some things are off the table, right? You might think that deception, covert medication in particular, right, treats a patient merely as an instrument for them improving. It might be motivated by beneficence, but might treat them as a kind of object, a barrier to their own care. Most of us don't think of ourselves as objects to our own flourishing. We think of ourselves as being of value in ourselves. If you've ever thought like, oh, I felt really icky about that situation, he was treating me like an object. Maybe it's an old phrase, he treated me like a piece of meat, right? That's this idea, like I'm not an object, I'm a person, right? I matter. And we can treat patients like bags of fluids in beds that we do things to. It's so easy to do that. Okay, consequentialism is an equally appealing way to think about ethics, but has a different perspective. Namely, it just thinks the way to think about the right thing to do is just make the world better. Regardless of what you do, all things considered, try to make things better from the point of view of the consequences you care about, namely reducing suffering, increasing happiness, promoting flourishing, promoting health. These are all great things. But you can see the tension, right? The tension between a deontological, duty-based perspective and a consequentialist perspective is just this. What if making the world somewhat better means treating some people as objects? Because they're interfering, right, in your efficient way of making the world somewhat better. Okay. I swear, this is the most boring part by far, this framework stuff. Then we're going to talk issues. But I want to get this language on the table so that we're going to get there. A number of nursing ethicists, beginning in the 1970s and 1980s, sort of read all this other stuff, right? They read about the Four Principles, and they read about like the deontology and consequentialism. They said there's a lot there, but there's missing something about what's unique maybe to nursing, about the sustained relationships of care. That nursing isn't about sort of abstract one-off judgments about the right thing to do. Medicine maybe sometimes is. But the physician who's in the room for 5 minutes, right, who meets with the family and the patient to come up with a plan of care, there might be a kind of one-off abstract planning sort of structure to the relationship with the patient. And we say this all the time, like they were never in the room. They like read the chart and like, you know, did this cursory assessment and then they walked out and they wrote some orders. And so one thing that's getting at is that nursing maybe is based on relationships in a fundamental way. And so Joan Tronto is a sort of leading philosopher, but also lots and lots of nursing ethics scholars have argued the fundamental ethical basis of nursing is the relationship of care. And that if you want to assess, are you doing right? Like, are you appropriately attending to that relationship? Are you being attentive to the right way to that person you're in relationship with? Are you being sort of responsible for your obligations of care over that 12 and a half hours that you're there with them, right? Are you showing appropriate competence, right? So studying right now, so you can not just pass the NCLEX, but actually be a good nurse, is an ethical obligation, I would say to you. I'm sorry, you have enough on your plate. I'm not trying to guilt you into studying, but like, people talk about passing the NCLEX. I hope you all pass the NCLEX, please, first time, right? 85, it's gonna be great. But that's like the lowest threshold you can imagine, right? Passing the NCLEX only means, as you all know, you have like a slightly increased chance of not killing your patients, right? NCLEX is like as low as you can get, right? And what care ethics is maybe saying under the idea of competence as part of an obligation of care, you owe it to these people who you are in a caring relationship with to be able to do the job well, right? I know, I'm not trying to guilt you, but like, technically being good at your job is an ethical obligation, yeah? Okay, and responsiveness, right? So are you paying attention to how the care is being received and how you are sort of mediating that care relationship? But this, if we get back to the question we began with, could coercing a patient, could manipulating a patient ever be a kind of caring? Lots of things happen to patients they don't want. Could just getting the patient up to ambulate after surgery when they really don't want to be a kind of caring if they're yelling at you to stop? I mean, maybe, if it is grounded in genuine attentiveness, if you're acting competently, right, if you're addressing their experience of the care, right? So this sort of framework doesn't point to abstract duties or overall consequences or four principles. It attends to the sort of the relationship. We ask, like, is this the right kind of relationship a nurse ought to have with a patient, right? It doesn't make the question go away, but it reframes it in ways people have thought are useful. And then finally, I think this one is very related to care ethics, but worth mentioning because I think it's helpful. Virtue ethics, which is a tradition that goes back to Aristotle and to Plato, argues that we just get off on the wrong foot by asking what's the right thing to do. Virtue ethics says the right question is, who ought you to become? Instead of saying what's the moral rules I should follow, virtue ethics says, what kind of person should you emulate? So if you've ever sort of been on a unit and seen, oh, that's a good nurse and that is not such a great nurse, and I want to be more like that nurse, I'm going to sort of emulate those practices. Like, that's a bit of maybe virtue ethics. You haven't broken it down into a series of rules that you want to follow. You've said there's a kind of character I'd like to develop. And indeed, I think in the Introduction to Professional Nursing class, at least when I took it, it has a very virtue ethical perspective, right? So beginning nurses learn rules and checklists, but more experienced nurses, they intuitively feel a certain way of being in the clinical space that involves a kind of clinical judgment, a kind of intuitive awareness, because you become a nurse, right? I mean, I'm a brand new baby nurse, right? Every time I'm on a floor, I feel like an imposter because I am pretending and I'm faking it. But what virtue ethics says, you fake it until you make it, or you pretend. I had a friend who was a gunnery sergeant in the Marine Corps, and as a staff sergeant, he had worked at Parris Island. You know what's at Parris Island, right? Marine Corps, like recruit training. And he's like, yeah, when I first started that job, I felt like such a ridiculous person, because if you've ever seen video of like Marine Corps drill instructors, they're absurd characters, right? They're sort of screaming and yelling with the Smokey the Bear hat, right? And he's like, yeah, it was ridiculous. And I sort of just was performing a role for like 4 or 5 months until I just became that guy. And now I am that guy. And you will perform the role of nurse until you are the nurse. And if you do it the right way, right, you'll develop these character traits. Okay. And then finally, I said that one was the last one, I lied. Finally, psychiatric nursing often involves the government, right, through petition and certs and judicial review, taking away people's liberty. We live in a free society where our rights to life, liberty, and pursuit of happiness are fundamental to the legitimacy of our very government, right? Various kinds of our liberties are enshrined in the Constitution. Psychiatric care involves violations of those rights. Those can be justified, right? But psychiatric care is very paternalistic in ways other care are not. And so one question to ask is, are these kind of liberty rights being violated in ways that can be justified? Right? Okay. Whew, so that was a lot. I promise no more theory. That was all the philosophy. We're done with the philosophy. Congratulations on passing an Introduction to Ethics class. You did it. Okay. Cases. Let's talk about coercion, because I think coercion is central to psychiatric nursing. I actually think coercion is more central to nursing than most of us are willing to admit. I think in nursing care, patients are routinely nudged, manipulated, pushed a little bit towards doing things they don't want to do for their own good, because otherwise they'd never get better, and we could never send them home. And I think that can be justified, but I think it's easy for doctors who are rarely in the room to say coercion's always wrong. It sometimes is necessary, I think. But let's talk about this. I think you can talk about a spectrum, right, of ways of trying to get people to do things you don't want to do. Lots of ways. If you've been or seen a very skilled UAP or aide or tech, there are some amazingly skilled aides and techs who can get patients to do things that, like me as a nurse, I'm like, I don't know, this patient doesn't want to get up. And you send that aide in there, and some combination of humor and threats and just like a very powerful voice, and they can work magic. And it's beautiful. You've seen this, right? You've either done or seen aides or techs just like do things that maybe you're like, I don't know how I could get the patient to do that at all. And they do it. And they like shut up and they take it and they get better. You can think about that sort of action along a spectrum, right? So persuasion and education, the use of rhetoric to get people to do something on sort of one end, or usually think that's okay. And on the other end is physically holding people down and doing stuff to them, which can sometimes also be okay, but the stakes of them harming themselves or others need to be quite high. And then there's sort of a bunch of intermediate steps between those that we can think about. I'm not going to go into it. You might say, well, look, Mark, and please do call me Mark. Look, Mark, as fellow nurses, there's a big difference between patients who are involuntarily hospitalized for psychiatric reasons versus patients who are legally hospitalized. Right? So all kinds of patients, right, on your unit are there because they agreed to be there. But have you talked to some patients yet on your, yeah? Is that part of the, yeah? I mean, they're there for all kinds of reasons, right? And many of them have chosen to be there. The literature shows that even among the legally voluntary patients, many of them report that they feel coerced as well, even though they have not been petition asserted. What matters is how patients sort of experience their care. So let's go back to this original case. I'm sort of curious what you think. Check in with me. Check in with each other first, and then we'll talk a little bit. What do you think about sort of persuasion, nudging, manipulating patients to take their meds because they are increasingly agitated, increasingly maybe decompensating, and you know that this is going to end up with them being held down and having an IM injection if they don't do what they're told. What do you think about that? Check in quickly with each other again after we've just been talking. I've been talking for way too long, and then I'm going to hear from you. Go. Let's go. So what do you think? No? Uh-oh, that's okay. Oh, let's bring it back. Let's bring it back. What do you think? Show me a hand. Just really quick, we're just going to do hands. It'll be low stakes. And then I want to hear what you talk. So just raise your hand. Anyone, if you're forced between A, B, and C here, I know I changed what they correspond to. How many people mostly think A? It's probably right. Some hands. How about people mostly think B? In the middle. And then mostly C. A few for C as well. Okay, well, let's go through. Anyone on A want to say about why they think A is probably the right answer? Which, I mean, A is basically saying, this is morally neutral. This is morally uncomplicated. There's no moral issues raised by this at all. They just with some education, persuasion, some rhetoric used, and the patient did what was good for them. What's the reason someone chose A? Yes, yes. Yeah, yeah. So, I mean, it's good for the patient, right? It's good for the patient. There are good reasons for them to take the medication they've been prescribed, right? Yeah. And we should communicate to patients what's good for them, right? We should definitely educate about medication, right? We're not generally prescribing medication, not within the scope of bedside nursing practice, but we are definitely educating them to the degree that we can. Of course, there are other questions physicians and other clinicians should answer. Nothing wrong with that. Any other people think A? It's just morally uncomplicated. Like, Navin, what are you doing? Like, this is the most routine thing in the world. Yeah? Okay, how about B? A lot of people were B. I'm a little sort of mushy about it. What are some thoughts here on B? Oh, I saw some hands. Well, what's this? If I throw things at people.
If you don't raise your hand, I'm going to throw it to you.
Oh my goodness. This is slightly coercive.
I know that.
I think we were a C
Okay.
though, yes?
Well, I said C.
Tell me about C.
I feel like it could be anywhere between B and C because depending on how she brought it up to the patient, but
Yeah.
like if she was like, if you don't take this, we're gonna give you the injection.
Nice.
Could be C, but if she was like, you should take this medication, the doctor might order you to get an injection. I feel like that could be more leverage than a threat.
It's a nice nuanced answer, right? So if she said, hey, you got to take the oral meds, or given that you're increasingly agitated, you're likely to get the IM, that maybe seems like a threat. Yeah? What do we think about that? Is that threat okay? Why not? I'm curious what you think. I mean, I'm not convinced that it's wrong. I mean, it is an accurate prediction of the future, probably. What do you think about that? Take this med, or you're likely to have it forced on you. Who's worried about that a little bit? Yeah, what do you think? You're just worried, Oh, just a hand. A hand is okay. What do you think? Just a hand. Yeah? Has anybody seen or heard about this kind of thing going on? Even on just med surg floors? Yeah?
No, at my psychiatric clinic.
Oh, you saw it?
I saw it happen to where they wouldn't take their medication, so someone came out with IMs.
Okay. So yeah, I mean, it does happen, right? Depending on what's going on with the patient, right? If they refuse their prescribed oral meds, like they can have it forced on them. Yeah, it does happen. This is not unusual. What do you think about that? I don't like a lot of things. What do you think? Yes. Okay.
Okay, we could have, or, if you're getting increasingly agitated, we might have to escalate this. We might have to see if the doctor can come see you, without saying, we're gonna put you in restraints and,
Yeah.
poke you with the needle. I
Nice.
think like a lot of it is in wording and in
Yeah.
education to not seem threatening, but still be like rational about the situation. So you don't want to lie to your patient.
That's nice. So you don't want to lie. You want to tell the truth about what's likely to happen because they need to have information to make choices. At the same time, I hear you saying you don't want to word it as a threat. A threat's disrespectful, right? A threat's, I mean, it's really using power to get people to do things. Yeah. Anyone else on this theme?
I think that some of it sometimes seems like the nurses, at least on my floor that I'm on, they're not very caring. They don't really want to be there, you can tell. So these people are going to get agitated when they don't feel loved and valued. I don't know.
Yeah, it's a hard situation to be in as like a fresh, like faced nursing student or like me, baby nurse, and be like, what happened to these nurses?
Yeah.
Surely there was once upon a time where they like were more caring. And I sort of wonder, I want to be sympathetic. I feel that. I've been there and I feel it. I wonder though, especially in psychiatric nursing, is there a benefit to being a bit more like cold, a bit more procedural, a bit more coarse? I don't know. I mean, I wonder yeah.
End all be all is medication over time.
Yeah.
Like there was a patient that was choking on my unit, like on the psych unit 2 weeks ago. And last week I went and saw him, like, and I never got like touching distance with him, but I said like, hi, how are you? He was so nice to me. I had a smile on my face. The other nurse was kind of just, I don't know, I didn't know if he was going to choke again or whatever. So I stayed away, but he was very cordial. Maybe he was medicated. I don't know.
Yeah.
But I just think it's the way that you kind of.
I loved my time on the psych unit. This is one of my favorite rotations because I got to talk to some really interesting people and they told me things that, what we're supposed to say, not that they were crazy. They told me things that I had never heard before. They told me things that I didn't know that was true. And they were all kinds of wild stories that I got to hear. And they were really lovely conversations. I wish I could just like write them down, right? Probably HIPAA violation there. Yeah. Other thoughts? Have you seen this kind of threats? Have you seen coercive treatment? Right? It's part and parcel of the game. And I'm trying to say, it doesn't mean it's wrong. If you guys need to take a call, you need to go to the bathroom, you got something going on, just go. Fine with me. But it does mean that it's worth thinking about why it's justified and why it's not justified. Because, how to put this, just because we have a bad feeling doesn't mean something bad happened. Our culture is telling us right now that anytime you have a bad feeling, like, oh, there's something wrong or toxic or whatever else. And that maybe sometimes our bad feelings are intuitions that point us towards good moral judgments. Sometimes we just need to like grow into the role that we're feeling uncomfortable about, right? And so, look at veteran nurses who you think are doing it the right way, right? And try and learn from that and talk to them about what they're thinking and how they're thinking through it. Because look, most of psychiatry gives me weird feelings if I'm thinking about it. Among other reasons, because I don't want to think about like how fragile my own mental health probably is. And I don't mean that by saying that I think I'm about to have a breakdown, but I just think I'm probably one terrible thing in my life away from having a mental health crisis, like probably most of us are. So psychiatry does sort of trouble me in ways that doesn't mean psychiatry is bad, but that I have sort of feelings to work on as well. So look, we can talk about coercion using these frameworks. Hey, I gave you a vocabulary, we can talk about it. One way to talk about coercion is the trade-off between, in the four principles, autonomy of the patient, they get to decide, self-determination, versus what's good for them. The four principles approach doesn't solve that conflict, but it gives us vocabulary to name it, to talk about it. Similarly, in care ethics, right? Is there a way that we prioritize the caring relationship, the preservation of the relationship through the context of whatever sort of persuasive or nudging or manipulative care was involved? Similarly, with virtue ethics, right? Would the nurse who has the practical wisdom and experience have done this thing? Right? When you think, I don't know, when I was a kid, this is how old I am, from the 90s, all of my evangelical friends were wearing WWJD bracelets. You still have those? What would Jesus do, right? And the idea there is emulation of the moral exemplar is the goal, right? So a similar perspective, right, is to ask, what would the sort of veteran nurses that you really respect do? And how would they think about it and emulating that? Okay, here's something that I've been thinking about. I've got a couple papers I'm actually writing on this. I mean, being a nursing student and now nurse has been so productive for me, actually. Nursing is so coercive in lots of ways. And one thing that's really troubling to me is that the people who have all the authority, namely the physicians, are like removed from the day-to-day coercive actions. And that the people who are doing a lot of the coercive actions, namely UAPs, nurses, aides, and techs, are like have all of this moral sort of responsibility because they're putting hands on patients, but they are not playing any real role in decision-making. And nurses are smack in the middle, trying to navigate both the kind of accountability for decision-making, and also, right, the sort of responsibility for the head-on coercion. And so one of the things that really interests me is like, how do you as a nurse, like how are you speaking to both directions? Because we talk about like delegation to UAPs in a kind of formulaic way, but you're not just delegating tasks, you're delegating ethically dirty work all the time. And I don't think we talk as honestly about the delegation of ethical dirty work and the insulation of the physicians, right, from the ethically dirty work. And nurses in the middle of it, right, looking in both directions. So I'm sort of interested in this. Okay. Let's do deception, and then we'll talk about that. So we're supposed to be honest to our patients. How else could they make informed decisions unless they knew what's going on? But let's talk about a case. So Mrs. R has schizophrenia. She's got a history of aggression. She refuses oral meds. Mr. R. His legal guardians authorized Haldol in his food. Covert medication. I'll show you in another slide that all the major societies say this is wrong, you shouldn't do it. Every nurse I've ever talked to has either done it or seen it. Covert medication. So the alternative, given his schizophrenia and his history of aggression, is going to be physical or chemical restraints. Or I guess Haldol is a chemical restraint, but it's going to be physical restraints. If he doesn't take his chemical restraint, he's going to be physically restrained. The sort of psychological, emotional, maybe physical trauma associated with physical restraints, much worse than the chemical. It'd be best for him to take the chemical restraint. The nursing staff's got to decide, hey, I've got a guardian telling me it's okay. I've got a patient for whom I know it's better to take this med than not. Should I do covert medication? So here, parent share again. I want you just talking briefly with your neighbor, right? And in particular, I want you to say, have you ever seen it or heard about it? Covert medication. Right? Covertly hiding patients' meds in food or other things. If you heard it, seen about it, or just heard other people talking about it, and then what do you think? Is it the right thing to do? Should we covertly medicate? Should we instead go to restraints? Because this patient's aggression is going to come if they don't get the med. What do you think? Go talk now, please. We're doing okay? We're doing okay? Okay. I never know.
I mean, obviously, I look at this and I'm like, this could be done rather than this.
Oh, yeah.
I mean, the most common verb has to do with patients with emotion.
Oh, yeah. That's good. That's a better case.
But with this kind of situation, it probably would be better to give them a long-acting injection. Once a month they get it and they don't have to swallow.
No, that's good.
But
No, but-
the dementia thing is big.
His dementia is much better.
Oh my
With dementia in a nursing home environment in particular. Yeah.
I mean,
And officially, it's like, you're absolutely not even supposed to do it. And like, it happens.
the applesauce is always spiked,
That's right.
but it's good. It's good.
Okay, it's good. This is one of my liabilities as someone who's trained in the theory is like, I don't have enough experience of the cases, right? So this is helpful. I got you. We're good. Good. All right, let's bring it back. Let's bring it back. I want to show of hands who has seen or heard about covert medication, especially like with dementia patients in nursing homes and their applesauce. Yeah. Someone over here said what the applesauce is always spiked. Is that what you said? Did you say that? Oh, who said that? You said the applesauce is always spiked. It's a real thing. Those of you who have never seen it or heard of it, what do you think? See? Find another way. Yeah, and there might be other ways. So maybe we're doing as the professor said, maybe a long-acting injection-based Haldol, right? Rather than relying on oral meds for a patient who's not going to be adhering to oral medication regimen. Yeah, I mean, I think find a better way. Yeah. Is it better though to like wait till the patient's actually aggressive and then do physical restraints? And if you've been in this cycle with this patient where they go off their meds, they stop taking their oral meds, and then they go through a cycle, they become aggressive, and then they have to be restrained. Are you going to be more open to covert medication? No? What are you going to do? You're going to quit. You're going to work somewhere else. You're going to be like, I'm going to go work at a dermatology clinic. Be an esthetician. It's going to be a lot. Warning though, I have a friend who did that and she quit because she's like, these clients are never satisfied because you can never make them look the way they want to look. So warning, if you think that's easy, those patients are rarely as grateful as you might want from what I hear. Okay, so deception, this is lying. If it's not lying, it's at least obscuring the truth. It's pretending this is just applesauce when actually it's spiked applesauce. What do you think? What are some of your intuitive judgments about deceptive medication? Right? What do you think? Yes, what do you think? Yeah. 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 So if what you're trying to do is reduce harms, especially if you have a consequentialist framework, where I'm like, look, at the end of the day, what's going to be better for them, right? And maybe you're like, yeah, I'd love a perfect world where I could talk them into it. That world doesn't exist. Let's get in the real world, and the real world only has dirty, broken options. Let's pick the least dirty, least broken one. I think it's a very, very sensible response. Yes, what do you think? Yes. I mean, pediatrics and like being a parent is all about coercion and deception. This is a nice point. You have a duty to yourself and to all your other loved ones to go home safe. I'm not saying like nurses are cops, but you got to think about going home safely. Yeah, that matters. That's people are like, oh, that's just you being selfish. No, no, you have an ethical obligation to yourself, to your loved ones, and frankly, to your future patients to not get beaten up today and not become a patient today. And that matters, right? That's got to be held in balance too. Yeah. Oh, okay. No stories for me. Other thoughts on this? Yes. Just covert. Yeah. Yeah. If there's no other way, if this is the best that we've got in this broken system, and here's something, how about we improved nursing staffing ratios? So you could cultivate better relationships, cultivate greater trust, and increase adherence to prescribed medication. Oh, we wouldn't have to do this. So it's interesting how the have to becomes the nurse's problem to solve on the unit instead of the CEO's problem to solve for the system. Again, I said I won't talk more about unionization, but notice, right, there's not a mistake that that's like a #1 priority is safe staffing ratios. Because yeah, you are going to be faced with fewer ethical problems of dealing with substandard conditions if you actually have better, more appropriate staffing ratios. Yeah. Other comments? Yes. Yeah.
With it completely oriented, or maybe they made decisions that brought harm to them in the past. So I feel like it makes me feel better that someone that knows the patient better than I might has also made the decision.
Nice. So you share the responsibility in a way with this guardian, right? Yeah. Good, good. And so maybe if we've got patients who are well into moderate, pushing severe dementia, right, and have guardians, then maybe we're more comfortable with some of this. What about if it's someone who currently has decision-making capacity, but they have an underlying mental illness that they're treating? And if they go off their meds, they're going to lose decision-making capacity, right, likely become aggressive. But at this moment, they've got decision-making capacity. Do your feelings about covert medication change in that situation if they currently have decision-making capacity? How do they change?
I feel like if they don't have the decision-making capacity, but they're still eating and all.
Yeah.
That's probably better for just get the medication without coming at them than I am.
Yeah.
They could become more agitated.
Sure.
Needle coming at them. But if they're logical and
Yeah. There are all kinds of people right now, maybe in this room, with serious psychiatric illnesses that are well managed with medication and therapies. But if they went off their meds, we'll probably not be doing as well. Do you feel as confident in that sort of case that covert medication of these people is as justified? If the outcomes are the same, but the kind of patient in front of you right now is different, right? So you see how I'm trying to pull apart, right? No.
Especially, well, psychiatric is just about who's afraid of people driving them food, but how can you go to enough people's practice to do that?
Yeah. Yeah, you're not pathologically paranoid if they're actually after you, right? Yeah, so this is actually consequentialism as a moral theory has a real problem because it says do what has the best consequences. How confident are you about what the consequences of covert medication would be? If one of the consequences is you undermine trust, so this person will never and no longer seek psychiatric care, well, good job. You probably reached worse consequences than you would have, right, by allowing them to decompensate and not covertly medicating. So one of the problems of consequentialism is we're really bad about predicting the future, right? Just to be clear, the ANA says don't do it for capacitated patients at least. American Psychological Association says don't do it. Depending on who it is, there have been opinions in sort of law and medicine journals. It might even be a crime, a kind of assault and battery on a person to medicate them against their will because you're doing something imposed directly on their body. It might be a kind of medical battery to do it, right? And yet it's really common, which shows you that people are struggling, right? You know, the nice people in the offices who wrote these policies maybe are not seeing what's going on the floor. Yeah, exactly. Let's have the people who wrote the ANA Code of Ethics work some med-surg floors or work in some nursing homes for a few months, and maybe they revise. And I want to be clear, as an ethicist, I want the Code of Ethics to be something that we can celebrate and act on, but in some situations, a lot of really well-meaning people feel like they can't. And so one point of talking about ethics is to reconcile yourself to some of that, to say, hey, this is not ideal. I'm going to do sub-ideal in the least sub-ideal way possible. I'm going to like get my hands dirty in a moral point of view, but as little dirty as possible. Okay.
Were to like put some more steroid medications in the alcohol and I ate it. That's not against the law.
I am not an attorney, and I'm not offering legal advice to any of you. And I would, yeah, it certainly seems like it wouldn't be. Yep. So it's, I mean, look, the official line, no, the official line is this is wrong, and you should never do it. But the pressure I'm trying to bring is we have these ethical ideals, and I have these ethical ideals, and yet living them in the moment, you're going to see a lot of good nurses, people who respect, people who've been doing this for decades, who are doing the absolute best they can, violating what looks like ethical ideals. And I'm inviting you, even if you ultimately decide that those nurses are wrong, to at least consider that they are doing their best under really imperfect circumstances, right? And you might find that you are compromising in some ways. And so one reason to talk through this is that to make sure that if you ever find yourself compromising, you're compromising as little as possible. And you're still holding on to as much of your integrity as you can. Because some people get in this mindset, hey, if I've compromised this much, then like I might as well just give up and do whatever. And I hope you don't think that follows, please. Yeah, don't become like this nurse I've seen where like on a med-surg floor, he's like, oh, I have too many patients. And he had like 6 patients, way too many patients, right? First thing he did was print off replacement wristbands for all his patients at the beginning of the shift, and then went to the Omnicell and pulled all the meds for like the full morning for all 6 patients, and then said that he gave them because he clicked all the bracelets, and then just put them all in his pockets. And then when he had time, would just like give the meds to the different patients. Please don't ever do that. I was like, this guy has just lost it. Like, I understand some compromises around the edges on little stuff. This guy, yeah, I mean, what if one of the patients got pulled for a CT and there were complications and never came back from the unit, but he said at 7:25 that he'd given all the morning meds, but he never did. I mean, so bad. And just mixing up meds and patients, oh, terrible, terrible. So
Then you have nursing dosing. Yeah, The order says Ativan 1 milligram IM or IV, and they're a little agitated, and you give Ativan 1.5,
Oh,
and then waste the other.
oh.
Oh yeah, nurses can be creative.
Yeah. And this is going to require really contextual judgment, right? Listen to the nurses you respect. Emulate what they're doing. Ask them questions about why, when you see people making shortcuts, why are they doing it? And ask it as a student. Hey, I'm new. I don't know. Can you tell me why you're doing that? That's a fine question to ask. I mean, don't do it in an accusatory way. My nursing professor said don't do that. Not that, yes? But hey, I see you're doing this. Can you tell me something about why you're doing it? And you might realize that that's the best that can be done in that situation. But you might also realize, you know what? I don't have to make that sort of compromise to my integrity. Okay. Oh, here's a question that pivots. Just want you to think about. Suppose our Mr. R, who we're covertly medicating, told us, hey, if I ever lose capacity, do whatever you have to do, just don't lie to me. And actually, I'd be okay with covert medication. Does that change your mind at all? Anybody ever heard of a psychiatric advance directive? Yeah, so you've heard of advance directives, right? So usually for decision making, when patients lose capacity, often at end of life. Oh, have you talked about psychiatric advance directives?
What's that?
So everyone said that you've heard of. So what's a psychiatric advance directive? You've heard of them. Who can tell me? Please.
Yeah.
Yes. Yeah. So one way to try and get around some of the worries about coercive treatment that we've been talking about in the context of psychiatric care, especially for people who've been like in and out, right, of inpatient psychiatric care, is they can write out in their lucid and capacitated moments, here are the things I want you to do to me to help me get better, because I want to be healthy and functioning. But I know that there might be moments in which I'm not making choices that are good for me. Here's what I'm willing to let you do for me in those moments. And in particular, I want you to listen to the me that wrote things down and not the me in the moment who's decompensating. So we're going to talk about that. That's our pivot here. So maybe you might think a little differently about covert medication if Mr. R had actually said in a psychiatric advance directive, or maybe had told his guardian or surrogate, please do whatever you got to do to get and keep the meds in me. So surrogate decision-making is huge. Someone mentioned before, having a guardian shares responsibility. It doesn't just share responsibility, it's someone who stands in for the patient. Ideally, we want a capacitated patient. We want the patient to decide. If you've got a good surrogate, someone who knows you, maybe because you even wrote it down or you just talked through it, then it's almost as good as having the patient decide if you've got a good surrogate. The surrogate decision-making is so important. I'm sure you've seen on med-surg, like, oh, we can't get in touch with the spouse, but we need to make a decision about surgery. Or, oh, shoot, they've just got 2 adult kids, and the 2 adult kids are arguing about what to do for mom. Like, huge source of ethical and tension for medical and nursing decision-making. Surrogacy is so important, especially for ill patients who can't make their own minds. Yeah, let's talk about this. So think about Maria. She's got bipolar. Between her episodes, she's fully capacitated. She takes her meds. She holds a job. She's completed a psychiatric advance directive. And part of that is she says, hey, when I'm in a manic episode, I authorize my sister to consent to mood stabilizers for me. Maria's now in a manic episode. She's shouting. She feels amazing. Because if you've ever, as I do, have people in your life who have bipolar, they love their manic episodes. Love them. I have a colleague, actually, who's a professor, who he can write a book in 3 weeks when he's in a manic episode. Amazingly productive. And then when he's depressive, he just doesn't get out of his, he hides in his closet. I'm not trying to make light of it. I mean, he makes light of it because it is sort of wild, but yeah, he loves the manic episodes. But she's feeling amazing. She doesn't need the medication, but the sister authorizes treatment. So the treatment team has to decide whose wishes control, because we have 2 Marias. We have the Maria who wrote the psychiatric advance directive, and we have the Maria in front of us right now. And both of them are people. Both of them are deserving of respect. Right? One of them is present, and one of them is in the past. One of them is capacitated in the past. One of them is incapacitated for decision-making in the present. So what do you think about that sort of case? So to frame the question this way, When there's a conflict between a previously capacitated patient who said what they wanted versus the patient in front of you right now who's saying what they want but lacks capacity, who do you listen to and why? Turn to someone next to you and let's say for a little bit. This is a big issue, huge issue in psychiatric care.
Why I know I'm a psych nurse.
Oh, yeah?
I mean, I do.
Oh, my goodness. Oh, wow. Like psych comorbidities are huge, especially with especially with like low SES patients who haven't been like getting care for years and years. And then like, oh, they show up at the hospital because their foot is rotting off because they're non-compliant with diabetes. And you're like, oh, shoot, they have 10 other problems too. Yeah. Yeah. Yeah, makes sense. No, and then like, where do they go? Yeah, no. What a mess. No, I sit on a weekly committee at the Royal Oak Hospital on difficult discharges, and it's all this stuff.
So this mic,
I love that. Oh, is that a microphone? I didn't know. I thought you were just throwing things at people, which I like.
I know you.
I was like, I didn't know. Okay, talk to me about this. Let's talk about surrogacy. I know many of you are younger than me. Does anybody have any advanced care planning documents? Has anybody filled out a durable power of attorney for healthcare decision making? So you picked who you want to make decisions for if you can't? Just a couple people. Why did you fill it out? Oh, does this work? Do we do this? Okay, good.
It does work.
Okay.
So I actually filled mine out when I was in the military. It was something they kind of walked everybody through.
Ah, yes.
So it was just part of something I did.
How did you pick who to make decisions for you?
I mean, at the time it was my mom. That's who I had. That's who I trust to make decisions for me. And then I had a long conversation with her about what I wanted, like at this moment, like what I want to be done for my care.
Yeah. So did you address things like, code status at end of
Yep,
life,
code
or artificial
status.
nutrition, hydration?
If I have to be intubated,
Yeah.
if I'm legally brain dead, all of those nice hard conversations at 18.
At 18, you had that conversation with your mom.
Yeah.
Oh my goodness. Thank you. Let's see, can we throw it back? What we're excellent, excellent. Sir. Who else? Someone else. Yep. Are you willing to share? Oh, good catch. Okay.
I come from a very open family, so we have a lot of these discussions. And so like I think I was like 18 too, and I learned about like what my parents were, and then I kind of like just talked about like what I would want in any of those situations.
Yeah. So do you have actually a durable power of attorney for healthcare?
Yeah.
You've written out? Where is it? Do people know where it is?
It's just in the safe at my house, like with everything else.
Fantastic. You can do it for free.
Yeah.
You're in the state of Michigan, it doesn't even need to be on an official form. All you need is to identify the person who you want to make decisions for you, and you need 2 witnesses that are not either family or members of your care team. And it can be legally valid. You can do it on a piece of paper right now. You should probably type it out and print it off. And lawyers will do it for a small fee, but lots of primary care providers will do them as well. And if you're ever hospitalized, right, you can usually ask like this, I don't know, social work or often care management will actually have materials pre-made that you can fill out. Michigan Advanced Directives. Yeah, highly recommend. Please do that. I don't know about you, but my biggest nightmare involves me being incapacitated and like medical things being done to me that I never would have wanted. Right? And like lingering there, like someone putting me like in a vent facility for 20 years and my body slowly rots. Yet you say no, but lots of loved ones are unwilling to make decisions you would have made. I mean, so I'm a professor. I don't know if I said this. I work like 5 to 10 hours a week at the Royal Oak Hospital as a clinical ethics consultant. And so we consulted on really challenging cases, often around end of life, often around potentially inappropriate care, often inappropriate code status. And often it's family who know that their loved one doesn't want what they're asking for, but they just can't let go. They're doing anticipatory grief, and they're expressing it by demanding inappropriate care at end of life. And when you lack a durable power of attorney for healthcare decision-making, who is going to actually do what you want, that nightmare can be your reality. So Think about these things, please. I know you're young and maybe you think you'll live forever, but you're not going to. I mean, let me tell you, I'm not afraid of dying. Or wait, I'm not afraid of my death. I'm afraid of dying with people torturing me in the hospital as I linger, right? So if you are afraid of that at all, write these things down. But here's a question about psychiatric care. What do you think about when it's one thing if the patient is intubated and they're not responsive at all and you just have to do things to them or not. What if you've got a patient who's telling you, no, I don't want my meds? And they're incapacitated, but they told you 6 months ago in this document that they do want them. And they do want them in this exact situation. Who do you listen to? The document. Show of hands, who listens to the previously capacitated person in the document? Who listens to the patient in front of you right now? Oh my, no one will raise their hand for that. That's very interesting. Why? Why are we so confident in the document? What do you think? Will you speak? Here we go. I'm gonna throw. Oh no! Oh no! Okay. Ooh, that was my worst throw. Okay. Here's is this close? Okay.
I was just thinking, like, they were capacitated at the time, like they had rational thinking. I don't know, that's what they wanted. They wanted it enough to put it in legal writing.
Yeah.
So when they're altered and incapacitated, they're not rational to make those decisions.
Yeah. Have you ever changed your mind about anything in your life?
Yeah.
I mean, suppose you wrote a plan 5 years ago for what you'd want to happen right now. Would you want to feel controlled by that plan? Now you might say, but I'm capacitated now. Does that always matter?
It's a good question.
I mean, one way to ask is, to what degree is the incapacitated patient in front of you still a sort of person whose preferences are worthy of respect and who has a kind of dignity that can be harmed by treating them over their objection? And I think they are, right, still very much persons, right, whose dignity can be harmed by treating over objection. Which invites the question, why fill out the dang Psychiatric Advance Directive in the first place if you're not going to follow it? But it's not so easy to know when to follow. It's not so easy to know who the patient is and who the person is. Did you want to say something? Yeah.
Feel like I know right because I'm still a nursing student, so I don't have experience with it. I don't know what I would do, but I feel like sitting here right now, if Maria was in front of me saying that she doesn't need it, I think I probably wouldn't until it got to a point to where she was wanting to self-harm herself or others. I feel like she still is a person. How do you know how manic she is? Maybe she is saying like, oh, I don't. So, and that kind of goes to like the right for refusal too.
Yeah. Yeah. And it's hard to know. I mean, just because someone is experiencing symptoms of disease, right, or symptoms that express a kind of irrationality, it doesn't mean that they don't have insight into some of their preferences, right? I mean, so one of the things I'm most troubled about, actually, in my own experience with healthcare, was when my wife had our 3 babies. She was very optimistic about avoiding analgesia anesthesia, right? She wanted to avoid the epidural, right? She wanted to do the sort of natural vaginal birth, right? And so she wrote a whole plan. She also wrote what's called, in this context, a Ulysses contract, where she said and discussed with the team, I don't want you to give me pain meds even if I beg for them. Here, yeah, she's like, I don't trust that future version of myself to keep with the plan. So here I am writing down and like signing. We got it like notarized. We were just young, naive kids. Here's this plan that I want you not to give it to me even if I ask for it and demand it. And in the first pregnancy, she got stuck around 8 centimeters and we were there for hours and hours and she kept demanding and eventually they gave her the epidural and she delivered and everything was great. And she was pissed afterwards. She was so angry. And I was like, lady, you were begging for the pain meds for hours. And the doctors are like, yeah, we'll give you a little more time. But eventually the doctors were like, hey, sorry, she's the patient. I don't care what that document says. And I was like, well, does she lack capacity because she's in so much pain? And they're like, yeah, that's why we're going to address the pain. I don't know what you're talking about. I'm to this day morally conflicted about how that played out. The second one, she wrote a similar document and did not get the pain meds and was delighted with the outcome. delighted that even though she asked for them, but she ran out of time. Basically, she begged for them. They're like, oh yeah, I guess we'll do that. And then by the time they were getting everything set up, she was already pushed in and we were done. I have very mixed feelings about who is the authentic patient, the former rational, capacitated self versus the one who's in the midst of it, be it extreme pain or psychiatric illness. I don't know. Do you have other thoughts? Hi there in the back. Hi. Hi, are you with us? Are you guys okay? Are you in this class? Yeah, I'm here. Are you here? Okay. What do you think about this? Do you have thoughts about this? Oh, okay. Are you okay? Okay. Okay. No, seriously, if you need to have a conversation, it's okay to go out, but I would love to pull you in because I do care about what you think about. Okay. One of the big tensions in surrogate decision making is between what's called substituted judgment. Are you deciding as the patient would have decided versus picking what's best for them, right? And sometimes these can pull apart. I had a case once as an ethics consultant where a patient, she had broken her hip, but she didn't want it fixed. She didn't want orthopedic surgery. And the reason was, she said, I'm a sincere believer in God and God will heal my hip. And it would reflect an absence of my faith for me to consent to surgery. So I'm going to lie here in this bed. I can't walk, but God will heal me, right? Yada, yada. So we had a psychiatric evaluation. It determined she lacked decision-making capacity because she had an unrealistic expectation about like how her hip was going to heal. Now, I don't know if that's in disrespect to her religion or the First Amendment, and you can take that up with the courts as you want, but that's what we decided. Here's the trick. Now we needed a surrogate decision maker. The person who was most close to her in her life was her sister, and that's who the patient wanted to make decisions for her too. And so we called up the sister. We said, hey, here's what's going on. Your sister, right? She's broken the hip, as you know, but we've decided she can't make her own decisions because she lacks insight into like her injury and the way it could heal. What do you think we should do? And what do you think the sister said?
Don't do it.
The sister said, don't do it. God is going to heal my sister's hip. Was the sister a good or a bad surrogate? Why?
But she was good to her sister. That's what she wanted.
What do you think? Was she a good or bad surrogate? Yeah. Yeah. Oh, I love that answer. I love, just to repeat it. She wasn't a good surrogate because she didn't respect the patient's wishes or patient's values, but she was a bad surrogate because she didn't do the patient any good. Look at this tension right here. That's the tension. Should surrogates fundamentally be in the business of representing the patient's values and wishes, or should they be fundamentally in the business of doing what's best for the patient? Those two things can pull apart, as they did in the case that I just said, and they often happen. In fact, we often, right, will decide a patient lacks capacity specifically because they won't do what we think is good for them. Very few patients who are adherent and compliant in doing what they're told will have psychiatry consulted to do a capacity assessment. Because obedient patients are treated as if they're just fine to keep consenting, even if they probably shouldn't be. It's the non-adherent, non-compliant patients, the literature shows this quite clearly, right? That you get the capacity assessment on because they're not doing what's good for them. Okay, but then you call in their surrogate, but a surrogate who chose for their own values, right, is probably not going to choose what's good for them. Really, really difficult, and especially difficult in psychiatry, right? Because lots of people experiencing mental illness have sometimes ambivalent feelings about the treatment of their mental illness, especially, right, when they're experiencing some of the symptoms of their mental illness. One of the big lies depression tells you is that there's nothing you can do about your depression. And so you don't want to take your meds or get out of bed or go exercise or eat better. And please treat your depression. I'm not against treating depression, but like, it's hard to say where the authenticity of that patient's values and wishes end and where the disease begins, especially when we're talking about surrogates. And so some people have suggested, as I've been suggesting, maybe a psychiatric advance directive gets around our coercion worries. I'm not so sure it does, especially if you're stuck with this decision between picking surrogates or respecting surrogates to the degree they actually respect the patient's wishes and values versus what's good for the patient. A real divide in debates. Also, psychiatric advance directives are basically never used. right? The literature shows only 20% of the time where they could be used were they used. It's also the case that durable powers of attorney and advanced care planning is rarely used, especially if you move between institutions. You have a DNR at your nursing home, but first you end up going to the emergency department, you are going to be full CPR on arrival. Now we've got recent law in Michigan that allows for standing orders for code status, but it is very imperfectly operated. So if you have a loved one who you don't want chest compressions done on, you better pay attention when they move between institutions because that code status will get reset. And similarly for psychiatric advanced directives, nobody's reading them or using them. So even if they could be a way out of our worries here, they are not being operationalized very well. I don't have any experience with these. Do you have any experience with psychiatric advanced directives? Are they, and why do you think they're not used well?
The same reason that you described. I mean, are they really incapacitated? Who makes that decision?
Yeah.
You know.
I mean, decision-making capacity was a concept invented by philosophers and pushed into the literature. But most decision-making capacity assessments in the charts are not actually done following validated tools. In fact, I've seen it happen. There's like 3 or 4 attending psychiatrists at the Royal Oak Hospital. 3 of them are great. There's one whose name I will not mention, who should not practice medicine. I've seen him do a capacity assessment. He walks in the room, looks at the patient, and then we'll write in the chart, yeah, you know, I talked to the patient lacks capacity. No real interaction. It's horrifying, actually. Horrifying. Right? Doesn't assess the patient's understanding of their disease, right, of their prognosis, doesn't assess their appreciation of the upshot of various interventions or non-interventions for their goals, doesn't assess their ability to reason comparatively about the costs and benefits of different interventions for their goals, doesn't even assess whether the patient has clear preferences, right? You would think. And yet it's systematically, decision-making capacity assessments are done terribly. If you know the history of psychiatry, right, entire studies have been done showing that completely sane people, right, if you institutionalize them, right, will be found by their psychiatrists to have various mental illnesses they absolutely do not have. Psychiatry is much more an art than a science, even today. And that's not to malign it. It's a really important thing. But we got to be very careful, as the professor says, hinging everything on decision-making capacity, especially in the case of these advanced directives. In the back, yes? That's a great question. And I mean, the answer is, I don't know. I would assume you're going to talk to your charge, you're going to talk to your colleagues, maybe you talk to the medical resident or whoever the surgery resident, whoever the resident on the primary service is, and express your concerns. And then my hope would be that we get a different psychiatrist to do an appropriate consult. I mean, look, lots of consulting physicians sometimes don't do a great job. I mean, they lie. The charts, I mean, you know this already, right? Paying attention. Pay attention to like how long the physicians are in the room, then read their chart note about how they claim to be there for 55 minutes. and all the assessments they claim to have done. Yeah, exactly. No, they're systematically committing insurance fraud. And we know it. You know it. They are systematically, there's one physician at our hospital who, actually the chief of internal medicine, did some research, sort of added up the hours. And he's like, look, I looked at all this guy's chart notes for one day. And if you added up all the time he claimed was spent in patients' rooms, it was over 30 hours. Like, I mean, so yeah, our system's broken. So what do? You advocate for your patient. You advocate with your colleagues up your chain of command. You advocate to the residents. You try and get a different consultant, right? When I'm on cases and I'm recommending a psych consultant, this is a name I never mention. So I don't know, but that's, I mean, the system's imperfect. Even if we had these perfect instruments, the system is so imperfect. Okay. Moral distress. So one of the upshots, one of the sort of major themes of nursing ethics is that nurses are parts of systems they don't control. You have an awful lot of moral responsibility. You have an awful lot of chances to get your hands morally dirty and very little authority. You are not generally, as bedside nurses, writing orders. You are not changing fundamentally the plan of care for patients. And so you can feel like there's the right thing to do and you have no way to make it happen. And so moral distress is the kind of attack on your integrity, on your sense of well-being, on your conscience of being compelled to participate in unethical acts and having no chance to avoid it, but always trying to choose the least unethical action. It is one of the chief causes of burnout. And unfortunately, plenty of nurses who burn out don't quit. They stick around for a long time. And that's toxic for everybody, including patients, but also other nurses. All right, so let's talk about a moral distress case in the context of psychiatric care. So you're a psychiatric nurse on a chronically understaffed unit. People call out and you don't get replacements and you are just trying to keep the boat afloat. You've got a patient, David, who's agitated, not yet violent. You believe de-escalation would work if you could just spend time with him, but you got to pass meds for some reason in this horrible case on 14 other patients tonight. Because people called out and your charge is not stepping up and you are stuck. The physician recognizes what's going and what's coming next and orders physical restraints on this patient. You object. You're like, look, it's not appropriate. This is a patient who doesn't yet need them. If I only had time, right, we could manage the situation. Your concerns noted. The order goes through. You have to apply the restraints. And David says, I thought you were on my side. Yes. Yeah. Good. So it is within, nurses can refuse, right? Yeah. So let's modify the case a little bit that like, because this is just my little paragraph, but let's add it to make the case better in this way that, you continually are pulled away from David. You believe you could spend more time with him, right? You could de-escalate, but you're continually pulled away to care for all your other patients. And every time you're pulled away, he gets more and more agitated. And like he's further and further away from you being able to de-escalate. And as the evening goes on, right, the order just gets written because he's so far gone. Yeah. 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 Good. Yeah. But suppose, and maybe this is me thinking through these cases. This is the first time I've given these slides, right? So I really appreciate the feedback on these cases. This case could be better. Suppose the case is just more generally this. If I had enough nurses on the unit, we wouldn't need as many restraints because we could spend time with our patients. But we're using restraints more than we should because we don't have enough nurses. And we got to do something to keep these patients safe when they decompensate. So the idea is about moral distress, right? The idea is like, what does this do? So the idea is not like, is this right or wrong? It's wrong. The idea is with you doing everything you can, how do you deal with the fact that there are a bunch of patients being restrained when you know if you had enough nurses, they wouldn't all need to be restrained? And you got to be part of it. That's the question. Moral distress, right? When one knows the right thing to do, but institutional constraints make it nearly impossible to pursue that right course of action. It's a term that was invented to describe the experiences of nurses. Moral distress, to a great extent, an organizational problem experienced at a personal level. Moral distress is when your employer has failed you, when your society has failed you, but they make it your problem. Yes, please. Yeah.
So this is the difference between ethics and law.
Good.
Okay, so let's be clear. If you put him in restraints and he didn't require restraints, that's false imprisonment. If you don't put him in restraints and he's agitated and you know that the nursing intervention is de-escalation in order to bring him down, and you choose not to de-escalate, that's called what? Neglect. Both of them are legal issues and both of them can be proven in the court of law that you didn't do your job. So this is where moral distress becomes an issue. I want to do my job.
Yeah.
But everyone above me that's supposed to support me to do my job is not allowing me to do my job. I have 15 people to take care of and keep safe, and I can't be available for that one patient. Or if I don't put him in restraints, something's gonna happen, so I put him in restraints even though he didn't meet criteria. And guess who's still responsible? You are. And guess who's gonna get sued? You are. So
Yeah,
we have to remember law and ethics
that's great.
work together, and sometimes they work against each other.
That's a really nice point. I just want to emphasize the point of moral distress is no matter what you do, you're doing something
Yeah.
wrong. And you're doing something, in this case, wrong from a moral point of view, but also from a legal point of view, right? You're not providing the care that you know is within standard of care, which would be de-escalation, right? But it might get so bad because you're not able to do de-escalation that the patient, for their own safety, has to be restrained, even if they shouldn't have been restrained if they actually got appropriate care. So then you've got, as you say, you're trying to navigate between two legal bad outcomes, right? Neglect versus battery and false imprisonment. And this is why distress is so powerful and painful. You start out wanting to do the right thing, and you can't. No matter what you do, it's wrong. And you're held responsible on a moral and legal way. And so the whole distress literature is just is not solving that problem. I mean, so I appreciate you trying to solve the problem. The whole moral distress literature is there's no solution.
Yeah.
You are stuck. And the question is, how do you go into work? How do you go on live with yourself? How do you protect yourself and your family and your patients and just your integrity and your character, knowing no matter what you do, it's going to be wrong? A couple of hands were here, yeah. Yeah, so like if they de-escalate to the point where they're in imminent risk of harm to themselves and you don't restrain them, then they hurt themselves, that's probably morally wrong and probably also involves legal liability. Again, I'm not an attorney giving legal advice, but yeah. But like what? I mean, the answer is not like some magical solution, because I don't have a magical solution. The answer here is just, how are you going to live with that? How are you going to get up and stare yourself in the mirror and say like, hey, there's a broken system and I'm risking my license, I'm risking my character every day. How do I hold on to as much integrity as I can? Go to therapy, support your fellow nurses. Work for policy change, work up the chain of command, engage in shared governance. And I said I wouldn't say it, but I'll say it again. If it breaks down, join your union. Unions are dirty. The Teamsters, I mean, you know, you might find out where Hoffa's buried, right? If you're the Teamsters, but like, they're one of the only ways to force safe practices in hospitals, and nurses who are unionizing around the country are responding to moral distress by, among other things, unionizing. Of course, it's nice to get increased pay and benefits and retirement, but primarily what nurses are often unionizing for is responding to moral distress. The system is not letting them do their jobs in ways that allow them to feel like they can be ethical agents and like reasonably follow the law. So moral distress is primarily a way to just capture the sense of moral injury or harm to the agent, in this case, the nurse, who can't do what's right. I don't know it works as a legal defense. I'm not offering legal advice. And to be clear, you're never going to be alone, right? You're going to have your fellow nurses, you're going to have your charge, you're going to have management that you can appeal to, but they're often not going to rescue you. I got a friend who's a nurse, and she's on a unit where charges take patients, but the fellow nurses can refuse to take additional patients. And so the last time she was charged, she had 9 patients while also being charged. And she said she was frantically calling management and everybody to come and rescue her, and no one would. And she's like, that's the last day I was ever charged. So yeah, I can't offer legal advice, right? And it might be, yeah.
When an attorney is suing because of damages to the patient.
Yeah.
When these things happen, like this situation where I can't do this, I can't do that, the actual attorney is gonna go after the system.
Yeah.
Because the system's broken. She couldn't do her job because the hospital didn't support her. So you're not only suing the nurse, you're suing the hospital.
Yeah.
So it's not an excuse, and it doesn't free you up because you have certain decisions that you have to make and, you know, legal responsibilities, But from an attorney's point of view for the patient, you didn't do your job, and you couldn't do your job because the hospital and the leadership did not provide you. So again, there it is. And then that's how they go about suing.
Yeah.
That's what you're trying.
And they're not going to sue you because you don't have any money. Yeah, you'll be named in the lawsuit, but they're not going to come after you. They want the billions from the corporation. Like you probably, yeah. Yeah.
Because the system is not supporting you to do your job to keep the patient safe.
Yeah. And this is where good nurses are finding ways to shortcut on things that don't matter as much, right? So you learn in nursing school the best way to do things. Every nurse I've seen in practice is taking shortcuts. And the question is, like, are those shortcuts justified to allow them to prioritize the things that absolutely matter, given that they're not able to practice nursing as it should be practiced? That's inadequate staffing is the top predictor of moral distress. The literature shows very clearly moral distress, which is itself the leading cause of burnout, is itself caused by staffing ratios. We just don't have enough nurses. Thank you. Thank you for becoming nurses. We need you. We're running out of time. So I want to do one more issue and then we'll wrap up. Is that good? Yeah? Confidentiality. When does protective privilege end? So can we go and tell our friends about all the patients we saw today? Especially not by name, right? Even if you don't use a name, using a date plus medical details can constitute protected personal health information, violate HIPAA as well. So be careful. Even if you're writing down anonymous case descriptions, be careful not to have like identifying information like the hospital's name or the date, right, on which it happened. Yeah? Probably good to change gender and ages if you like keeping track, because sometimes it's good to keep a reflection journal of like difficult cases that you've been thinking about. Try not to keep identifiable information. But yeah, we're very careful about this, right? Very careful about how you're accessing the chart. I know my preceptor was always like nervous if I got more than like 5 feet away from the computer terminal while I had Epic pulled up or something, right? God forbid, Joint Commission walked by and saw. Confidentiality matters. Okay, but what about in psychiatric nursing where other people might be at risk of harm? So consider a case during group therapy on a locked psychiatric unit. James, your patient, says he plans to hurt his ex-girlfriend. And suppose he says how he's going to do it, the day he's going to do it, and he walks through with great detail and makes it very clear this is something he intends to do. Later, though, he tells you privately, oh, I was just venting. Please don't tell anybody. That was just something I had to share in therapy. He says, if you report it, I'm never going to trust another clinician again. You're going to interfere with my recovery. I'll never get better. Please don't tell anybody. And the nurse believes him. She's like, look, he seems like a good guy. I don't think he'd really do it. He just maybe was working through some thoughts here. But she also knows that psychiatric prediction of violence is really unreliable. Psychiatric clinicians are really bad at figuring out who is going to commit violent acts and who is not. So that's our question. Should she tell? Quick show of hands. How many people think she should tell? How many think, no, she shouldn't. You don't want to undermine the clinical relationship. Okay, I wrote a bad case because everyone's on one side of it. You actually have a legal obligation in many states, including Michigan, to tell under the conditions that I specified. There's a California Supreme Court case, most famously cited, called Tarasoff, that argues the protective privilege ends where the public peril begins. Right? So what happens in therapy, what happens in the medical record is usually kept very confidential. The exception is sort of direct threats of physical violence against an identifiable person with an apparent intent to carry it out. And you have to disclose. It doesn't mean you as an individual disclose, but you have to go up the chain of command, right? And make sure the information gets disclosed. Michigan law, right, makes it very clear that even nurses, right, have an obligation to disclose and that it doesn't violate confidentiality to do that, right? But how do you know? What's the difference between a direct or indirect communication of a threat? How identifiable does that potential victim need to be? How much do you have to judge the apparent intent and ability to carry out the threat? Have you heard people in the throes of psychiatric illness talk about violence, either directly or indirectly? What about a patient where it's the patient themselves who's talking about violence? You've heard this? Yeah? What? And you'd be both legally liable and probably ethically liable, right? You would feel, one hopes, some moral responsibility. But the sort of gray dividing line is some people talk about, I have friends who talk about like, oh yeah, the person may be so upset, God, I wish something bad would happen to them. right? Like that's not a direct threat of violence, right? Maybe that was rude to say, right? You know, hope they would fall off a cliff. Like, wouldn't feel badly if they died tomorrow. I mean, these are horrible things to say, but that's not a direct threat at all, yeah? And so there's going to be these sort of gray zones, but it's about saying your moral responsibility to confidentiality has limits, right? And that's part of what we've just been talking about today, is that all these ethical principles and ideals that people invoke, they have limits because there are other ethical ideals and principles that come from the other direction. And figuring out that tension, right, is the real work of becoming a responsible, like grown-up nurse, right? Can you think through this in a critical way? There's no easy checklist that's going to answer these questions for you. Can you engage in sort of veteran critical thinking about this? So yeah, there are good reasons to warn. There are good reasons to be cautious. Like every sort of unsettling thing that's said in therapy shouldn't just be told to people outside of therapy. That undermines the whole idea of therapy itself. Yeah. I mean, I've been in therapy times in my life. I'm glad no one told my wife or my kids some things I said. That would not be good. But I didn't threaten to hurt anybody. So that's the difference, I suppose. Okay. So just by way of wrapping up, and I've really appreciated your engagement today. We have talked about a number of different cases: coercion, deception, surrogate decision-making, moral distress, confidentiality. And as I just said, all of them involve a tension between moral ideas pulling in opposite directions. And that's, I mean, everything in life is about ethics, but most of life is not about ethics tensions, right? So like loving your kids or your friends is an ethical thing to do, right? But we don't sit up at night worrying about it because there's no tension pulling us usually in the other direction. Most of nursing involves ethics, right? Care, right? And what you're doing is this good thing to do. You're fulfilling various duties all day long when you're caring for your patients. But the hard stuff is when there's a tension, when you're pulled in multiple directions. And so I hope we spent an hour and a half together. You were really engaged. I thank you for that. I hope we talked about some language that would be useful in naming these problems, in identifying the tensions, and some resources for you to think about how to have conversations with other nurses up the chain of command. And you don't have to call it an ethics problem. You say, I'm having a problem about this thing. How do you think about it? You've been doing this for a long time. How do you think about this kind of issue? That on-the-ground practical knowledge is your best way to move forward. So I really enjoyed our time together. You have a quiz coming up, so I don't want to get in between you and that. Any questions before we end for me? Well, thank you. Good luck in your future as nurses. Thank you very much. Thank you for your engagement.